I'm Kaveh Ardalan, one of the pediatric rheumatologists now at Duke University, which is a Cure JM Center of Excellence in Juvenile Myositis. And excuse me, I'm going to be talking about new treatments in juvenile myositis, some of what was discussed at this conference that we just had by Zoom. But just in brief, why do we need new and better treatments for our patients, our kids with juvenile myositis? The first is that this is often a condition that's chronic and even in some cases tough to control completely. It can come back as a flare or be tough to control in the first place. And a lot of our patients have a tough time tapering off of steroids and need combinations of existing treatments. We know that disease activity and sometimes even damage from this condition can persist into adulthood. And even our patients who get into states of remission often still are kind of deconditioned, still complain of some weakness and fatigue, despite having what appears to be no inflammation in the body. So we wonder what's going on there. How can we get at that? And then, of course, as everybody here knows, the current treatments that we have, like steroids, methotrexate, and so on, have a lot of side effects. So recognizing the need for new treatments, it's just been wonderful to partner with folks at Cure JM and really try to think about how we can advance, a community of scientists to try and really make progress on this front. And so on October 17th, this webinar was co-hosted, Cure JM Foundation, and then our team at Duke. Particularly, I want to give a lot of credit to Dr. Jeffrey DeVergston, who's my co-directing partner for our Center of Excellence. He really did a lot of the organizational work along with Andrew Heaton and Jim and everybody else at Cure JM. And together, Andrew, Jeff DeVergston, and then Dr. John O'Shea, who's at the National Institutes of Health, provided some different introductory remarks, both about the state of treatments for kids with JM, as well as some of the potential biological targets that some new medications might be able to kind of go after to decrease inflammation in the muscles and skin. And then I also provided some closing remarks about the patient's voice in all of this. So there were a lot of different treatments and new drug targets that were discussed. The ones in bold below are the ones I'll kind of focus on since our time is a little bit limited. So one medication called Baricitinib, which there was a recent compassionate use trial whose findings were published by Dr. Hannah Kim at the National Institutes of Health. Vamorolone, which is being developed by a company called Reveragen, and Dr. Eric Hoffman of Reveragen presented on that. And then Abatacept or Abatacept, depending on how you like to pronounce it, presented by Dr. Rodolfo Curiel, also at the National Institutes of Health. But there was also some discussion of sodium thiosulfate, which is a treatment for calcinosis, and then some other novel drug targets. And if folks have questions about those, I'm happy to address those. So Baricitinib, this is a type of medication called a JAK-STAT or just JAK inhibitor. And I won't go into a ton of detail about what exactly that means, but suffice to say, there are a lot of different ways that the immune system creates inflammation. And one of those pathways through which inflammation is produced is through what's called the JAK pathway, which then leads to a lot of increase in something called interferon, which is a type of family of molecules that seem to really drive a lot of the inflammation that kids with JM are experiencing. So Baricitinib is thought to block this pathway, among others, and that's why it seems like an attractive option for patients with JM. So Dr. Kim at NIH presented results of this very small but interesting compassionate use trial that she was able to conduct and publish on. What they were able to accomplish is to get 4 patients who have chronically active juvenile dermatomyositis, despite having been on anywhere between 3 and 6 different immunomodulatory medications. So these are patients who have pretty tough to control JDM. And they were able to start Baricitinib and continue it for a 24-week trial period. And what they found was pretty encouraging, that in all 4 of the patients, there were significant improvements in the skin rashes, strength exam, muscle inflammation as measured by MRI tests, and then also some blood markers of inflammation that you would expect should respond to a JAK inhibitor like Baricitinib. So here are actually some pictures from the publication of the study findings. And as I mentioned, there are 4 patients. Each of these kind of like dual pictures are from a different patient. So you're kind of getting to see a little bit of the response across all 4 patients. And what you can see is, first of all, some of these patients did have pretty substantial rashes. And in some cases, those rashes seem to clear completely, as you can see in the patient whose eyes are shown. They have heliotrope rash on the left, and then it really cleared by the time that they were at this point of study completion. Some significant improvements in the nail fold capillaries, which are those small blood vessels that you can see in the nail bed in the upper right. Almost entirely clearance of the purplish rash of the thigh that you see in the lower right. And then although there wasn't total clearance of this quite severe chest rash, nevertheless, there was some significant improvement in that. And then without trying to like go into tons of detail, what these different charts are basically showing is different ways of measuring how active a patient's dermatomyositis is, all showed improvements. So panels A and B in the upper left and the kind of top middle, those are physician and patient ratings of how active the disease is on a 0 to 10 scale. And what you see is that the scores tend to go down over time. That's a sign of improvement. The upper right is a measure of strength called MMT8, and you want this to go up. You want higher strength, right? And you can see that in general, patients had improvements in strength. In the lower left is a measure of skin rash disease activity, and it's called the CDASI. And for all of the patients, at least some significant improvement was noted. Particularly 3 of the patients seemed to have pretty dramatic improvements. And then panel E, so the kind of lower right and lower center panel, those are showing some different blood markers of that are related to interferon, the pathway that should be decreased by baricitinib. And as you can see, there is a decrease. You will notice, like in the center panel, this little spike here for this patient who's depicted in red. That was actually a spike that was noticed because during that study visit, that patient had a viral infection, and you should actually expect a brief increase in the interferon level. That was actually thought to be reassuring because it suggests that although this is an immunosuppressive medication and you have to worry about risk of infection, nevertheless, this patient seemed to mount a good response to clear that viral infection. So overall, this is a small study, but it was really nice to see that this was a well-tolerated medication, that all 4 patients were able to tolerate it without major side effects. The key risks of this medication that will need to be considered as we go towards bigger and bigger studies would be, number 1, infection, and that's true for any immunosuppressive medication. Although it's worth noting that in these 4 patients, many of them were able to decrease their steroid doses and decrease how many other immunosuppressive medicines they're on. And so it makes you wonder if that might kind of balance somewhat the infectious risk of baricitinib. Something worth noting, if ever you have a time when your child is on baricitinib, this type of medication interestingly increases the CK muscle enzyme level. That is not a sign of worsening myositis necessarily. This is seen in patients with other diseases as well, like rheumatoid arthritis. And it's not exactly clear why that happens, but it's not usually like a huge rise. It's just a subtle increase. So this is why in this study, they also used MRI and detailed strength exams to really make sure that the muscles are healing in these patients, since the CK may not be as reliable a marker. And then with this medication, you want to monitor kidney and liver function appropriately. And then there have been some reports in other studies, not in this one, of a possible increased risk of blood clots. That seems to be mostly in adult studies. We don't yet know if that's the case for kids who are on these types of medicines. So something that we'll be looking out for. But overall, the patients in this study didn't have major issues with this treatment. So future studies are being planned both to assess the effectiveness and safety of this drug in more patients with JM, and then also to better understand what are the mechanisms by which it acts, how much is it acting on interferon versus other non-interferon pathways. So vamorolone is the next medication I wanted to talk about. It's what they are calling a novel dissociative steroid. So what does that mean? So traditional steroids, such as the well-known medication prednisone, are very potent at decreasing inflammation. And that's due to some molecular mechanisms that go by the name transrepression. This has to do with how the medication triggers certain changes in the biology of a person who's receiving them. But steroids are a double-edged sword. They decrease inflammation really effectively, and that is very helpful for kids with JM. At the same time, they have tons of side effects like weight gain, growth stunting, and on and on. And those negatively impact both quality of life and health itself. And those effects are mediated through a different set of mechanisms that are called transactivation type mechanisms. So the idea behind vamorolone is that it's essentially the molecule for this drug is structured a little differently so that what it's supposed to do is give you that potent anti-inflammatory effect that you want without triggering the mechanisms through which the side effects happen. And that seems to be what we're finding so far in some studies. This is a drug that was predominantly developed for use in Duchenne muscular dystrophy. So it hasn't been tested in JM yet, but so far in patients with Duchenne muscular dystrophy, they were able to enroll 46 boys who are young. They're between 4 and 7 years of age. It's important to note only boys get Duchenne muscular dystrophy. And they were treated over an 18-month period. They were found to have good motor outcomes, good ability to, in terms of like strength and ability to walk compared to patients who were receiving traditional steroids like prednisone. And the higher the dose of vamorolone you gave, the better the effect, which is always a good sign for a novel medication. But what was important is the improved safety profile that was seen. So they didn't see growth stunting in the kids who got vamorolone. There were lower rates of physician-reported changes in appearance that you expect with steroids. So as we all know, like if you're on steroids for even a brief while, you start to have kind of weight gain, and so rounding of the face, weight gain in the stomach area. That's called Cushing appearance, and that was not really noted very much at all in the kids on vamorolone. And then we also know that a lot of kids on steroid medicines will have major behavior changes, really intense mood swings, sadness, anger, anxiety, all very common in kids on prednisone. That wasn't really reported often in kids in this study. So the other thing that's worth noting, is that there was a prior publication before this study came out that suggested some blood markers that should correlate with bone health, risk of diabetes, and adrenal suppression, that those markers suggested that vamorolone was not causing as much trouble in those regards as well, although further studies needed to get at that. So bottom line, there are some differences between Duchenne's and JM to consider, especially in regards to the fact that the majority of JM patients are girls, and that's not true of Duchenne's. So future studies need to consider that. The total number of patients who've gotten vamorolone and been studied rigorously is still small in the absolute sense, so more studies are needed. And JM does follow a different course, and the use of steroids is somewhat different in kids with JM, who often get these big pulse IV doses of steroids at the beginning of their treatment. But nevertheless, we think it should be possible to study vamorolone in kids with JM. There are some blood markers that might be helpful for assessing its effects in kids with dermatomyositis. And currently there's some planning underway between folks at our center, myself included at Duke, folks at Cure JM, and then the folks at ReveraGen. So we're trying to think about how to make this happen. And then last is Abatacept in kids with refractory JM. So this is a biologic medication, and basically what it does is it inhibits the co-stimulation of T cells. So what does that mean? Basically means these immune cells called T cells, normally in kids with JM, they're kind of communicating with each other in a way that revs them up, and that increases inflammation. So Abatacept is a medicine that kind of inhibits that communication between the T cells so that they calm down and don't produce so much inflammation in the muscle and skin. And there were some cases reported of severe adult and juvenile myositis patients who did well with it. So there's been interest in studying it more rigorously. There's a pediatric study going on right now at the NIH and Dr. Curel. It cannot present the data yet because the study is not complete, but they're recruiting into that study and doing the analyses. But encouragingly, there was a pilot study done in adults with dermatomyositis and polymyositis that was promising. So they had 20 patients in total who received Abatacept. excuse me, and they did note improvements in muscle strength and total improvement scores, which account for all different facets of this condition. And the safety profile was good. So those authors called for future studies with larger numbers of adult patients, and we think that this makes sense to pursue in the pediatric world as well. So it's a lot to cover, and I'm sure there's a lot more we could say about these and other treatments, but bottom line is that it's great to have support from our partners at Cure JM to push these studies forward, and we are endeavoring to do so. I think it's going to be extremely important to really incorporate patient and parent perspectives into the design and reporting of these trials. And it's the biggest barrier that we face in studying new treatments is getting patients enrolled into studies. This is a rare condition. There's never going to be one hospital that has enough patients to enroll fully up to the appropriate number for a study. So this always has to be a collaboration between multiple sites. And so if you ever think that your child might benefit from a novel treatment, or you'd like to see if they qualify for studies, ask your physician to reach out to partners at Cure JM who can connect your physician to the different researchers. So thank you, everybody.